Hi everybody, welcome to our module on cirrhosis. Cirrhosis of the liver is end-stage liver disease. It is an irreversible form of liver disease that can result from a number of different chronic liver conditions. Some of the most common are viral hepatitis infections, especially with hepatitis B and C viruses. Both of these can cause chronic liver infections. Cirrhosis is also commonly a result of alcoholic liver disease and sometimes non-alcoholic fatty liver disease. Cirrhosis results in a shrunken liver where the liver tissue is replaced by fibrous tissue and nodules. This is a drawing on the screen of a cirrhotic liver. The normally smooth liver surface is replaced by these bumpy nodules of fibrous tissue, and you can just think of it as the liver becoming scarred from chronic inflammation. The clinical features of cirrhosis are easy to understand if you know what the liver normally does when it's healthy, and one of its most important jobs is to process ammonia and convert it into urea via the urea cycle. So if the liver is failing from cirrhosis, patients will develop hyperammonemia, and the symptoms of elevated ammonia levels in the serum include asterixis. This is a flapping of the hands when patients extend their hands, also confusion, and it can progress to coma. There are a couple of treatments that can be used in hyperammonemia to lower the serum ammonia level. The first one is a low-protein diet, since ammonia comes from metabolism of amino acids. If the patient eats less protein, that will lower the serum ammonia level. Now, I should note here that a low-protein diet is not recommended for patients with cirrhosis any longer. The reason is because even though it did lower the ammonia level, it led to malnourishment, which was sometimes fatal. So for this reason, patients aren't specifically advised to eat a low-protein diet any longer. But I put this on the slide because you should understand the theory behind it, which is less protein in the diet leads to lower ammonia levels. The second treatment is lactulose. Lactulose is a synthetic disaccharide. It's a sugar molecule that functions as a laxative. In the colon, it's broken down by bacteria into fatty acids, and this lowers the colonic pH. So anytime the pH in the colon is lowered, it favors the formation of NH4 plus over NH3, and NH4 plus is not absorbed and gets trapped in the colon. So the result is that the patient has more bowel movements because lactulose is a laxative, and those bowel movements contain lots of ammonia, and therefore the plasma ammonia concentration falls. The other clinical features of cirrhosis result when the liver fails to conduct other normal processes. So the liver is supposed to metabolize bilirubin. When it doesn't do that, the bilirubin level rises in the serum, and that leads to jaundice. This is a picture of a man with jaundice shown on the screen here. It's the liver's job to perform gluconeogenesis and also to break down glycogen to keep the blood sugar level normal between meals. So when the liver doesn't do that job, hypoglycemia can occur. The liver produces clotting factors, so patients with cirrhosis can develop an elevated PT-PTT. This is called a coagulopathy. And then finally, it's the liver's job to produce albumin. So in the setting of cirrhosis, patients can develop hypoalbuminemia. This may cause a low oncotic pressure because recall that albumin is the major driver of oncotic pressure. And when you have low oncotic pressure, you can develop ascites and edema. So let's drill down on the concept of oncotic pressure because it represents an important tie-in between cirrhosis of the liver and blood flow mechanics, which I discuss in the cardiology section. So cirrhosis of the liver can have an impact on capillary fluid shifts. Recall that there are two forces which control the movement of fluid out of the capillaries and into the tissues. The first force is called the hydrostatic pressure P sub C. This pushes fluid out of the capillaries into the tissues, as I've shown at the bottom of the screen. There is a second force called the oncotic pressure pi sub C, in which proteins, especially albumin, pull water into the capillaries. Proteins like albumin cannot cross the capillary membrane, and thus they draw fluid into the capillaries and out of the tissues. This means that they resist the movement of fluid out of the capillaries. So in the setting of cirrhosis of the liver, when you have a fall in the amount of albumin in the serum, this can lead to a fall in the oncotic pressure. This means that more fluid will be pushed out of the capillaries, and this contributes to the phenomena of ascites and edema, which we'll talk more about in the next few slides. There is another set of clinical features related to cirrhosis that all result from abnormal metabolism of estrogen. Normally, the liver removes estrogen from the serum, so in the setting of cirrhosis, the estrogen level can rise. In men, this can cause gynecomastia. This is a picture of a man with gynecomastia on the top right of the screen here. You can see the development of breast tissue due to elevated estrogen levels. And then two other consequences of elevated estrogen are spider angiomata and palmar erythema. This is a picture of a spider angiomata on the screen here. You can see it's a red lesion on the skin. It's the result of increased numbers of blood vessels below the skin. The mechanism for this is not entirely clear. And on the bottom right side of the screen is a normal palm. If this patient had palmar erythema, you would see redness in the hypothenar and thenar eminences of the palm. That's a characteristic feature of cirrhosis of the liver. And I've always remembered both spider angiomata and palmarothema from thinking that estrogen can make your skin red. If you just remember that basic fact, it's easy to remember these two features of cirrhosis of the liver, spider angiomata and palmar erythema. Another potential consequence of cirrhosis of the liver is portal hypertension. Recall that blood flows from the intestines through the portal vein and then through the liver and then into the hepatic vein, and from there it goes to the IVC in the right side of the heart. If you have cirrhosis of the liver, you can develop obstructed blood flow through the liver. This results in high pressure in the portal vein, which is called portal hypertension. And here's a drawing on the screen here just to show you that blood moves through the portal vein and then through the liver and then into the hepatic vein. So if you have obstruction to blood flow through the liver, you will get high pressures in the portal vein. This is a good point to pause and talk about the hemodynamics of cirrhosis. So as we discussed previously, there's a fall in albumin level, which leads to a fall in oncotic pressure. This means that fluid can leak out of the capillaries, and this can decrease the effective circulating volume of plasma that is perfusing tissues. There's a second phenomenon going on, however, that's much more important that you need to know about, and that is vasodilation. In cirrhosis of the liver, there is an increase in production of many vasodilators, especially nitric oxide, and this controls and dictates many of the hemodynamics of the condition. The increase in vasodilators leads to vasodilation, especially in the splanchnic vessels, which are vessels in the abdomen. This leads to a fall in systemic vascular resistance, which is a hallmark of cirrhosis of the liver. This means that patients can have a low blood pressure, and low blood pressure is common among cirrhotic patients. This can activate the sympathetic nervous system and lead to an increase in cardiac output, which is also commonly seen in patients with cirrhosis. But more importantly, the fall in SVR combined with the fall in oncotic pressure decrease the effective circulating volume of plasma. In other words, the effective circulating volume of blood that is perfusing tissues. So the body responds as if there is low volume and poor tissue perfusion. This means that there's an increase in activity of the renin-angiotensin-aldosterone system and increased ADH release. This leads to salt and water retention, and this leads to retention of fluid throughout the body and an increase in the total body water. So along with heart failure, cirrhosis of the liver is one of the classic conditions in which you have an increase in total body water, yet a fall in the effective circulating volume of plasma. In other words, a disconnect between the effective circulating volume and the total body water. What this means clinically is that patients with cirrhosis of the liver will develop ascites and edema. As we just saw, there's an increase in total body water in cirrhosis. We've also discussed why there is portal hypertension in cirrhosis. The high pressure in the portal system combined with the increased total body water leads to ascites, which is fluid in the peritoneal cavity. In addition, the increase in total body water can lead to lower extremity edema, and then the low albumin level also contributes to both of these phenomena. Importantly, you should know that you must have portal hypertension in order to develop ascites. Patients with cirrhosis but without portal hypertension do not develop ascites, and so this element is key, and when you see a patient that has ascites on physical exam, you know that they have portal hypertension. A very important consequence of portal hypertension that you need to understand is the development of venous collaterals or venous anastomoses. These are blood vessels that are normally small and collapsed but become dilated and engorged in the setting of high portal pressure. To understand this, I want you to imagine two veins. Imagine we have a vein that's draining blood into the systemic system. I'll write SV for this vein, and it's draining blood to the inferior vena cava, for example, and back to the right side of the heart. Now imagine we have another vein and it's draining blood into the portal system. I'll write PV for this one. In the setting of portal hypertension, the pressure in this vein that drains to the portal system can get very high. Normally present in the body are small channels connecting these two veins called collaterals or anastomoses. They are normally small and collapsed because both veins are draining blood equally well and the pressure is not high. However, when the pressure becomes very high from portal hypertension, these collaterals or connections between the systemic vein and the portal vein system can become dilated and engorged. They can become twisty and full of blood, and those are called collaterals, and those are responsible for many of the clinical consequences of portal hypertension. So I've summarized these points on this slide. The high portal pressure opens venous collaterals, which are connections between the portal and systemic veins. These are normally small collapsed vessels, but they engorge in portal hypertension. And there are several different venous collaterals that tend to swell and engorge in portal hypertension that you need to know, and we'll go through all of them in the next few slides. Around the umbilicus, venous collaterals can swell, and this leads to a physical exam finding called caput medusa. In the esophagus, collaterals can swell, and these can lead to upper GI bleeding. In the stomach, there are also collaterals which can swell and lead to bleeding. And then finally, in the rectum, there are venous collaterals which can engorge and lead to hemorrhoids, which may also bleed. I'll talk about the different collaterals one at a time now, and I'll begin in the esophagus. So a varix is a dilated tortuous blood vessel. Varices, therefore, are multiple dilated tortuous blood vessels, and esophageal varices can develop as a result of swelling of collaterals in the esophagus and portal hypertension. Recall that most blood from the esophagus drains via the esophageal veins to the SVC. That's shown on this picture on the screen. This blue structure here is the esophageal vein draining blood from the esophagus. However, a small amount of superficial blood is also drained via the left gastric vein to the portal vein. The left gastric vein is also sometimes called the coronary vein, and it's shown on the screen here, draining the esophagus. There are collaterals between these two structures that are normally small and collapsed, but when the portal pressure gets high, that raises the pressure in the left gastric vein. It swells these collaterals, and that leads to the development of esophageal varices. This is a picture of what esophageal varices look like via endoscopy. You can see these swollen, bulging veins. These are just like the veins you can see in your hand if you clench your fist, but they're present in the esophagus. And you can imagine how dangerous it would be if one of these were to rupture. The patient could exsanguinate, and this is one of the ways you can die from cirrhosis. Remember also that most patients with cirrhosis have a coagulopathy, so they are prone to bleeding, and now they have dilated tortuous blood vessels in their esophagus. It is a setup for bad things. You can also develop varices and portal hypertension in the stomach. These are called gastric varices. There are vessels called short gastric veins that drain blood from the stomach fundus to the left gastric vein and the splenic vein, both of which are part of the portal system. Not shown on this picture here are short gastric veins which connect between the splenic vein and the left gastric vein. When the portal pressure gets high, these blood vessels can swell and dilate. These can then bleed, and that can lead to upper GI bleeding from gastric varices. Caput medusa is a physical exam finding of engorged blood vessels around the umbilicus on the abdomen. It results from collaterals between the periumbilical vein and the epigastric veins. Around the epigastric area, periumbilical veins drain blood into the portal system. Epigastric veins drain blood into the inferior vena cava. Collaterals between these two venous structures can become engorged and swollen, and that results in caput medusa. Caput medusa gets its name because it looks like Medusa's head. Medusa was a Greek mythology character, and she had snakes for hair. So if you look around the umbilicus, you will see these veins going off in directions like this, looking like snakes, and that's how it gets its name, caput medusa. Internal hemorrhoids may also occur in portal hypertension from venous collaterals. Internal hemorrhoids are hemorrhoids that occur above the dentate line. They are collaterals between the superior rectal vein, which drains to the portal system, and the middle and inferior rectal veins, which drain to the IVC. These collaterals can become swollen, and this can result in hemorrhoidal bleeding in patients who have cirrhosis and portal hypertension. Lastly, let me mention hypersplenism. The spleen can become engorged in portal hypertension because the spleen is drained into the portal system via the splenic vein. The important clinical consequence of this is that many patients with portal hypertension have low platelets, and the mechanism of the low platelets is engorgement of the spleen via hypersplenism. You can develop portal hypertension without cirrhosis of the liver, and one of the ways this can happen is if you develop a blood clot in the portal vein. This is a rare cause of portal hypertension. It presents as the acute onset of abdominal pain when the clot forms. There will be splenomegaly on exam and a palpable spleen from the hypersplenism. The patient may develop gastric varices with bleeding, but importantly, the liver biopsy will be normal. And a classic case for a board question is to describe a patient with portal hypertension symptoms, and the liver biopsy is normal. They ask you for the cause. The answer is a portal vein thrombosis, and this is a way of testing whether you understand what could raise the blood pressure in the portal system if the liver is normal. Ascites can result as a result of cirrhosis of the liver and portal hypertension. Ascites is the accumulation of fluid in the peritoneal cavity. This is a picture of a patient with massive ascites. You will see many, many patients like this on your clinical rotations. The abdomen is distended and tense if you press on it. In liver disease, this can happen for two reasons. First of all, portal hypertension can drive fluid out of the plasma and into the peritoneal cavity. In addition, low albumin lowers the oncotic pressure and favors the movement of fluid into the peritoneal cavity. When patients present with new onset ascites or ascites that is much worse compared to their baseline, you can perform a test to determine whether the ascites is coming from portal hypertension, and that test is called the SAG, which stands for serum ascites albumin gradient. It's a test of the acidic fluid. There are basically two reasons patients can develop new or worsening ascites. The first is portal hypertension, which we've been discussing. The second is because of a malignancy that involves the abdomen. This can lead to a leaky vasculature, and that can also lead to ascites. So one of the ways you can sort this out is to measure the sag. And to measure the sag, you first take a sample of the ascites fluid via paracentesis. Paracentesis involves sticking a needle into the swollen abdomen like we saw in that last slide and drawing a sample of the fluid. You then compare the ascites albumin concentration to the albumin concentration in the serum. If you subtract the ascites albumin from the serum albumin, you will determine the sag, or the serum ascites albumin gradient. If the sag is high, greater than 1.1, this means there's a large difference between the serum and ascites albumin concentration. And this is what happens in portal hypertension. The high pressure in the portal system drives fluid into the peritoneum, but the vasculature is intact, so albumin remains behind, and as a result there's a large difference between the two albumin concentrations. If the sag is low, less than 1.1, this is what's seen in malignant ascites. There are malignant cells in the peritoneal cavity. This is leading to a leaky vasculature that allows both fluid and albumin into the peritoneum. As a result, the albumin level is similar between the serum and ascites. And on your clinical rotations, you will measure the sag many times in patients with ascites. Usually it's from portal hypertension, that's the more common cause, but you will do this to rule out or exclude a malignancy involving the peritoneum. The initial therapies for ascites are very similar to the therapies for heart failure. In both cases, you want to remove fluid from the body. So one of the things you can do is restrict sodium. When you restrict sodium, this leads to volume contraction, and this can lower the amount of ascites present in the abdomen. Beyond sodium restriction, you can use diuretics, just like we do for heart failure. The drug of choice for ascites is spironolactone. It's a potassium-sparing diuretic. It blocks aldosterone in the distal tubule. I talk about this drug in detail in the renal modules. It's been used for decades for ascites. For reasons that are not entirely clear, it's more effective than other diuretics and is always the first-line drug of choice. If spironolactone is insufficient, you can add loop diuretics. These are second-line therapy. These are drugs like furosemide. Beyond sodium restriction and diuretics, you can perform large volume paracentesis. A paracentesis is removal of fluid from the abdomen via drainage. Some patients with cirrhosis go to see their liver doctor once every few weeks, and they have a liter or two of ascites drained from their abdomen, and this reduces the swelling and reduces the amount of abdominal pain. Beyond these therapies, the final therapy is a surgical procedure called a TIPS. TIPS stands for transjugular intrahepatic portosystemic shunt. It's a treatment for portal hypertension that involves creating a channel in the liver that connects the portal vein to the hepatic vein. If you look at this picture on the screen, in the top left corner, image A, we see the hepatic vein at the top and the portal vein at the bottom, and the portal vein has high pressure from cirrhosis of the liver. In a TIPS procedure, a device is inserted via the jugular vein, that's why it's called transjugular in the name, and that device is pushed through the hepatic vein, through the liver, and into the portal vein. This creates a channel so that blood can flow between the two structures, and a stent is left behind to leave a permanent connection between the portal vein and the hepatic vein. As a result of this connection, blood can be drained away from the portal system and the pressure will fall in the portal system, and this will reduce the amount of portal hypertension. One of the complications that patients with ascites can develop is something known as SBP, or spontaneous bacterial peritonitis. This is infection of the acidic fluid. Bacteria from the gut can sometimes gain entry into the acidic fluid in the peritoneum. It's usually gram-negatives like E. coli and Klebsiella. Rarely it can be strep or staph. The way this will present is in a patient with known ascites who develops fever and worsening abdominal pain and tenderness. You can sample the acidic fluid via paracentesis and measure the number of neutrophils. If it is increased, which is greater than 250, that suggests infection. And this is commonly treated with a third-generation cephalosporin like cefotaxime. The reason is because this drug provides good gram-positive and gram-negative coverage, and it's also known to achieve good levels in the acidic fluid. When patients have cirrhosis of the liver and chronic liver disease, there are a couple of scoring systems that are used to determine how severe the patient's liver disease is. One of those systems is called the MELD score. MELD stands for Model for End-Stage Liver Disease. It estimates the 3-month mortality for patients with liver disease. It's a point system where you calculate a point total using the bilirubin level, the creatinine level, and the INR. And if you get a point total greater than 40 for the MELD score, that suggests a 71% mortality in 3 months. Less than 9 is very low. That suggests a 2% mortality. Now, they're very unlikely to ask you to calculate the MELD score in step 1, but I want to point out here the factors that go into the MELD score. It includes things like the bilirubin level and the INR, and the reason those are included is because when those become abnormal, it means the liver is truly failing in its job of either metabolizing bilirubin or synthesizing clotting factors. Note that other things like the AST and the ALT are not included in the MELD score, and that's because those things don't predict mortality very well. They suggest liver inflammation, but they don't tell you how well the liver is functioning. The other system that's often used is called the Child-Pugh classification system. This system uses 5 variables to predict the risk or survival in patients with chronic liver disease. It's a point system, and you get points for having encephalopathy, ascites, elevated bilirubin levels, low albumin levels, or an elevated PT. The score you calculate ranges from 5 to 15. 5 or 6 is called Child-Pugh Class A, 7 to 9 is Class B, and 10 to 15 is Class C, which is the worst. And you'll often hear clinicians talking about the patient's child class, and this is what they're talking about. Class C is the worst, Class A is the best. The gold standard for diagnosis of cirrhosis is a liver biopsy, but this is often not required if it's clear from history. For example, if a patient with known chronic liver disease develops signs and symptoms of cirrhosis, you usually know what the diagnosis is. The biopsy is only done when it will change management, and remember that patients with cirrhosis have a coagulopathy, so biopsying the liver is particularly dangerous. Sometimes imaging is used, like ultrasound or CT or MRI. It will show a small nodular liver. It's not particularly sensitive or specific for a diagnosis. One of the best uses of imaging in patients with chronic liver disease is not to diagnose cirrhosis, but to look for hepatocellular carcinoma. In some of the other modules, I talk about how patients with chronic liver disease are at risk for this cancer, and you can screen for it with these imaging modalities. The more common way cirrhosis is diagnosed is clinically if there's presence of ascites or low platelet count or spider angiomata. If you see things like this, you know the patient has cirrhosis and you've made the diagnosis. The last topic I'll mention for this module is something that's very high yield for step 1, and that's a cell type that's been shown to play a major role in the development of cirrhosis. It's called a stellate cell. It's a perisinusoidal cell, meaning you find it on the sides of the sinusoids in the liver. It's a storage site for retinoids, which are vitamin A metabolites, and it's been shown to be active in liver disease. There is a significant amount of basic science research into what these cells do and why they do it in cirrhosis. They can secrete TGF-beta, and they can proliferate and produce the fibrous tissue that you see in cirrhosis. They're a major contributor to the disease. If you look at this picture at the bottom of the screen here, the blue is portal blood flowing into a sinusoid, trying to reach a central vein and go to the hepatic vein. Along the sides of these sinusoids, you can see a cell right here, and that is a stellate cell. This is where they sit, just off the side of the sinusoids, and as I said before, it's high yield to know that they're a major contributor to cirrhosis of the liver. And that concludes our module on cirrhosis.